welcome to everyone to this new webinar of International Academy of Cytology about the WHO International Reporting System for Pancreaticobiliary cytology given by Professor Marta Pitman. Marta Pitman don't need any further introduction. She is well known in the field of cytology, and she is a professor of pathology at Harvard Medical School and director of a cytopathology laboratory at Massachusetts General Hospital. She obtained her residency and fellowship training in Boston. She is the past president of the Papa Nicolau Society of Cytopathology, and she's also the current president of American Society of Cytopathology. She's associate editor of the Journal of American Society of Cytopathology and lead author of PSC Pancreaticobiliary Terminology System for reporting pancreaticobiliary cytology. And for sure is her clinical research is devoted to all kinds of cytology, but in particular to pancreatic cytology, to the detection of early pancreatic cancer, and also in the study of mucinous pancreatic cyst. This webinar will be recorded, and you can also have a look to the past webinar of IAC. You can go on the International Academy of Cytology website, and there you have a link to all the webinars. So thank you, Marta. It's really a pleasure to have you here and to start the series of this webinar on the new WHO International Reporting System for different organs and systems in cytology. Thank you, Marta.
Thank you, Dr. Bongiovanni. I really appreciate the invitation to speak to everyone today about the WHO system for reporting cytology, and I'll focus today on pancreaticobiliary cytology. The WHO systems was developed with an agreement between the WHO, the International Agency for Research on Cancer, and the International Academy of Cytology. They joined forces to create an international reporting system in cytology that mirrored the WHO classification of tumors with links between the books. It includes key diagnostic cytopathological features, establishes risks of malignancy per category, discusses the ancillary studies for diagnosis, and recommends subsequent diagnostic procedures and patient management. There is an emphasis on morphological differential diagnosis that helps low and middle income countries where there may be a relative lack in histopathological and ancillary testing services. Under development are 4 books. There is the Pancreaticobiliary book, which we'll be talking about today, the book on pulmonary cytology, lymph node cytology, and soft tissue cytology. There is a standing committee, or series editors, if you will, that is composed of Dr. Andrew Field from Australia, the current president of the IAC, Dr. Ian Cree from the IARC WHO, Dr. Fernando Schmidt from Europe, the upcoming president of the IAC, myself, and Dr. Ravi Madrota from India. Now today I'm going to focus on the pancreaticobiliary system. This is just a mock-up cover, it's not the final cover. Now the pancreaticobiliary system has an expert editorial board that includes the standing committee members plus Dr. Barbara Centeno from the United States, Dr. Mauro Sayeg from South America, Dr. Lester Lacefield from the United States, Michelle Reed from the United States, Ed Stilo from the United States, Momin Siddiqui from the United States, Lola Lozano from Europe, Miguel Perez Machado from the United Kingdom, Noriyoshi Fukushima from Asia, and Dr. Birgit Weinan from Europe. But there are many, many other contributors throughout the book from all over the world. Now, the WHO system is a springboard of a reporting system on the back of the Papillary system of cytopathology for reporting pancreaticobiliary cytology that was developed in 2014 and codified in book form in 2015. This system, the PSC system, had 6 categories: non-diagnostic, negative, neoplastic, that was divided between a benign neoplasm and other neoplasms, and suspicious for malignancy and positive or malignant. And this system was relatively unique for reporting systems because it emphasized the importance of clinical and imaging features, understanding what those features were, and applying them across the cytomorphology and the ancillary studies that importantly included biochemical and molecular testing of cyst fluids. Now, in this system, there was the non-diagnostic, which means you can't give a diagnosis, you don't have anything to report. The negative for malignancy category, which included non-neoplastic entities only, your atypical category, your neoplastic category, where you know you have a neoplasm and you can define it as benign, that's dominated by your serous cystadenoma, or other neoplasms that included a broad range of pre-malignant and low-grade malignant neoplasms, suspicious for malignancy, and positive for malignancy. Now, the neoplastic other category in the PSC system was the controversial category because it did include both pre-malignant and low-grade malignant neoplasms, but that was done on purpose to allow for more flexible patient management for these low-grade malignancies and potentially high-grade intraductal lesions that didn't have quite the throughput for diagnostic accuracy and management options that were becoming increasingly conservative. It's very difficult to convince a patient to have conservative management, watchful waiting when their pathology report says malignant. Now, this PSC system was evaluated in studies all over the world. A study from Australia emphasized that the imaging context and cyst fluid analysis was very important for the interpretation and how that helped to categorize these pre-malignant and low-grade malignancies. This study from South America showed that the PSC system greatly impacted the indeterminate categories of atypical and suspicious, because now we were able to classify certain lesions as definitively neoplastic. And this study from the United Kingdom showed that the PSC system had a high sensitivity and specificity and overall accuracy in classification of tumors and the risk of malignancy. And this study from China showed that there was a better ability to risk stratify in the PSC system. But that was actually one of the problems with the PSC system, was the risk of malignancy in this neoplastic other category, because it did include intraductal premalignant lesions as well as low-grade malignancy. So as you can see here, the overall risk of malignancy in the neoplastic other category was only 30%, but when you stratified those intraductal lesions between low-grade and high-grade atypia, which was the dominant lesions in this neoplastic other category, then you had a 90% risk of malignancy when you had high-grade epithelial atypia, which also included the cystic neuroendocrine tumors and solid pseudopapillary neoplasm. So this great disparity between the risk of malignancy led to a problem with category 4 overall risk of malignancy. So we needed to do something about that in the WHO system. And so the WHO system for reporting cytology is classifying tumors as the WHO Blue Book does classify tumors. And because of that, we now have solid pseudopapillary neoplasm as well as neuroendocrine neoplasms classified as malignant. So this is the WHO system that, let me just try to move this thing out of my way and I can't see it. So the PSC system, and the WHO system are now side by side to show the differences between the two in red. So here we see that the WHO system has an inadequate, insufficient, or non-diagnostic category. And I'll explain why we have three different terms up there in a minute. And then we have our benign, if you prefer, negative for malignancy category that now includes both non-neoplastic and neoplastic entities that will still be dominated by your serous cystadenoma in the neoplastic category, but now serous cystadenoma is in category 2. And we still have an indeterminate atypical category, but the neoplastic other category is now split into two distinct categories. Pancreaticobiliary neoplasm, low risk, low grade, or you could for short say pan-low, and pancreaticobiliary neoplasm, high risk, high grade, shortened to pan-high. And these two categories are dominated by your intraductal lesions. Low-grade spindle cell lesions can also be in the pan-low, and high-grade spindle cell can be in the pan-high if you were worried about a malignancy in that regard. But they're very rare lesions in the pancreas, so by and large, the lesions in these two categories are going to be your intraductal lesions, and of those, your IPMNs are going to dominate those. Then we have an indeterminate suspicious category and a malignant category. And again, the pan-net or pancreatic neuroendocrine tumor and your solid pseudopapillary neoplasm are now in the malignant category. And when we look at risk of malignancy in this WHO system, obviously it's a new system and hasn't yet been applied, but using the data from our prior PSC cohort and recategorizing the lesions according to the WHO, we come up with this estimated risk of malignancy of 5 to 25% for your insufficient, inadequate, non-diagnostic category, 0 to 15% for benign, 30 to 40% for atypical, 5 to 20% for pan-low, 60 to 95% for pan-high, 80 to 100% for suspicious, and 99 to 100 for malignant. Now, we did split off the bile duct brushing risk of malignancy because it really does have a distinct risk of malignancy. As we know, we have a very high threshold for malignancy in bile duct lesions. We don't want a Whipple specimen or a hepatectomy specimen on our bench for reactive atypia, which we know causes a tremendous amount of atypia. So we do have a high specificity in our diagnosis of bile duct brushing specimens, but a relatively low sensitivity. So we have 75 to 90% risk of malignancy in the suspicious category and up to 50% in atypical. Now, this is a draft table. There's one other new study that just came out in early 2022 that we're trying to incorporate into this table. So the numbers may change a little bit in the final version in the book, but I think this is a pretty good approximation. Now, we don't have any data, obviously, on the pan-low and pan-high for bile duct brushing specimens. I think that these two categories will very unlikely be used for bile duct brushing specimens because we really don't have a good grip on the surgical criteria for the intraductal biliary lesions. They're particularly rare, and in my experience, I've never made a diagnosis of those intraductal biliary lesions with confidence. More often than not, we're going to put it into the atypical or suspicious category unless there's unequivocal malignancy criteria. And so the multimodal approach is still being used in the WHO system. And importantly, I'd like to take this quote from Syed Ali, who I just love this quote because it says, "The eyes cannot see what the mind does not know." And so if you don't understand what the lesions are in the pancreas, what their imaging characteristics are, the demographic information associated with some of the lesions, the cytomorphology and biochemical testing, molecular testing, all of these features, if you understand the lesions and what these characteristics are, then we can apply them in a very algorithmic method to come up with a pretty reasonable diagnosis at the end. But it does take looking at all the puzzle pieces together to come up with a really good diagnosis. And we also need to make sure that we communicate what we know and what we see to our clinical colleagues in a very standardized report that includes all the information that our colleagues need to know. Generally, all of our pathology reports come with generic, demographic informations of the patient name and identifiers, who the referring doctor is. The type of specimen obviously is important. Is it an FNA or a bile duct brushing? Is it bi-EUS or transabdominal? That's important information to know, especially for an FNA of the pancreas, so you can understand what contaminating epithelium may be present. We want to know on imaging features. Is it a solid mass or a cyst? That can divide our differential diagnosis from the beginning. You can have a summary if you have multiple parts, say a bile duct brush, an FNA of a cyst, an FNA of a solid component. You can summarize it, that's optional. And also, sometimes optional is your adequacy component. At Mass General, our laboratory information system has a specific specimen adequacy category in every report. So it's either satisfactory or it's limited. It can be limited by scant cellularity. It can be limited by air-dry artifact or obscuring blood. And that often is used to explain why the diagnostic category may be indeterminate, atypical, or suspicious. But use the diagnostic terminology, not a number. So if it's atypical, say atypical. If it's pan-low, write that out. Don't say category 3 or category 4. And then you have a diagnosis, and it gives a clear communication of what the interpretation category or diagnostic category is, which is associated with the risk of malignancy and follow-up management, and then your specific diagnosis. And you can put an explanatory note or a comment with your ancillary testing, a microscopic description if you need to. So let's look at the different categories. The first category is insufficient, inadequate, non-diagnostic. And why we have all three options here, because the editorial board and the standing committee could not agree on which was the best one to use. Obviously laboratories have their own preferences and their own patterns, and the clinicians understand what you mean when you say that. And in my lab, we use non-diagnostic because we want to make it very clear that we have a specimen that was processed and evaluated. So we have at least bill information and we can be paid for what we've done, and that we just feel that the information on the slide is not enough to make a diagnosis. Inadequate can be the same thing. You don't have enough cells to make a diagnosis. Insufficient means the same thing. Preferably, I use non-diagnostic, but you can use something else. But what it means is it's a specimen that for qualitative or quantitative reasons does not permit a diagnosis of a targeted lesion. It includes normal pancreatic epithelium with defined mass on imaging. So for example, a well-defined, well-circumscribed, clearly visible image on ultrasound, and all you get is normal benign pancreatic tissue. That's non-diagnostic, even though you have slides full of cells. But an option for that is you could say benign pancreatic tissue, and in a note have a caveat that says it doesn't explain the mass. That can be a personal choice as well. My concern with using benign is that the risk of malignancy in that category it may be artificially inflated because of that classification. Whereas non-diagnostic or insufficient, you're not representative, clearly says it's a non-test and you need to go back and get more. And the risk of malignancy in this category can be quite high. But we don't want our risk of malignancy in a benign category to be very high. And so for this category, it can be up to 25% in the pancreas. We don't know really what it is in the bile duct brushing category because most studies exclude non-diagnostic or insufficient bile duct brushing specimens. And the use of ancillary tests can decrease the use of this category. For example, biochemical testing of cyst fluid can decrease the non-diagnostic. If you don't have any epithelial cells, but you have cyst fluid with a CEA of 500, we know we're dealing with a mucinous cyst, and we can put it in the, at least the pan-low category with the caveat that there are no epithelial cells for grading. And the repeat FNA and brushing is warranted for this category. So for example, what I was just mentioning, here is a well-defined lesion seen on EUS, and an FNA gets only normal benign pancreatic tissue. So is this benign or is this non-diagnostic? I prefer that this is non-diagnostic, normal pancreatic tissue. The biopsy does not explain the pancreatic mass. But if you prefer, you can say it's negative for malignancy benign, say the same thing. But your risk of malignancy now in this category is elevated, more likely than not. Here's another example where you have an evaluation limited by preparation artifact. This is a very low power image of nothing but blood in the background, and then this fragment of tissue that is obscured by thickness and blood in preparation artifact. You can't see through this tissue. There are no single cells in the background. So you could say unsatisfactory here, tissue entrapped in blood clot and fibrin, precluding cytological diagnosis or evaluation. Here's another example. You could say inadequate. I would say non-diagnostic, gastrointestinal contamination only. The FNA is not representative of the pancreas or target lesion. So we certainly have tissue on the slide, but it's a transgastric FNA with all of this benign gastric epithelium. It does not tell me anything about the target lesion, so it's not adequate, it's insufficient, and it's non-diagnostic. Here's another example. A patient has a 3-centimeter unilocular cyst in the pancreatic head with a mural nodule, which is a high-risk imaging characteristic, but all we have is this non-mucinous, maybe a little bit of scrump of mucin in the background, but I'm not sure if that's lesional or contamination, and these are just histiocytes. So we have evaluation limited by absent epithelial component. It's non-diagnostic. We know we have cyst fluid. We received cyst fluid. We processed cyst fluid, but it only has a few histiocytes. So we have biochemical testing. We look that up for every single case in our laboratory information system. We see that the CEA is very low. The amylase is moderate, but that doesn't tell me anything about the cyst. I can't classify it one way or the other. I know I have molecular testing pending, but I'm not going to get it for 2 weeks, so I can't say anything about this cyst fluid. It's non-diagnostic. But I alert the clinical team that there is molecular testing pending and they can look it up. It may be informative. Here's another example. What do you say, non-diagnostic or negative? Sometimes we may not be able to give a specific diagnosis, but we'd like to maybe tell them a little bit more information that helps them manage the patient. For example, this 1.5 centimeter unilocular cyst in the pancreatic body, they see has a connection to the main pancreatic duct. That imaging characteristic tells them they're dealing with a branch duct IPMN. So am I going to say that this is absolutely negative, or am I going to say this is absolutely non-diagnostic? What's more beneficial to the clinical team? Well, they know it's a branch duct IPMN. So what they want to know from me is there anything to say that this is a high-risk cyst? Does it need to come out, or can they manage that patient conservatively? I can see some extracellular mucin, but I don't see any epithelium. I see this degenerated debris within that mucin, but nothing to say that this is a high-risk cyst. So I can put this in the negative for malignancy category. I can explain that I do see mucinous cyst fluid. I don't see any high-grade epithelial atypia, and I can say that I'm confident that this mucin is from the cyst. I see the degenerated debris that supports that. I have an elevated CEA, but it's not at my cutoff of 192. So it's elevated, but I have to stick to my criteria of 192. So I can't put it in the neoplastic mucinous cyst category or the pan-low category, but I don't really want to say it's non-diagnostic. So as long as I explain what I see, that I don't see high-grade epithelial atypia, it doesn't look high risk, I'm comfortable saying that it's in negative for malignancy and the patient could be managed. Here's another example. Multilobulated multicystic mass in the pancreatic body in a patient with von Hippel-Lindau syndrome. Well, more likely than not, that patient's going to have a serous cystadenoma based on this imaging characteristics and that history. But all I have on my slide are hemosiderin-laden macrophages and no intact epithelium. So, you know, there's a surrogate marker for serous cystadenoma, or these hemosiderin-laden macrophages. But so is it non-diagnostic or is it negative? I personally prefer to put this in the benign negative category, even though technically it's non-diagnostic. I don't see any extracellular mucin, so I can say I have non-mucinous cyst fluid with hemosiderin-laden macrophages and no epithelial cells. So I'm not making a specific diagnosis. I can't say that it's definitively a serous cystadenoma, but I can say that the CEA is low, the amylase is low, and those findings support the fact that I have hemosiderin-laden macrophages. It kind of goes along with the imaging, the clinical history. It's more likely a serous cystadenoma, not definitively diagnostic. If I had molecular testing, maybe they'll, you know, find a von Hippel-Lindau gene mutation in that cyst fluid, which would add support to that being a serous cystadenoma. So there are nuances between negative and non-diagnostic. Can you at least give some information that is helpful to the clinical team, or is it completely not helpful at all? This is not non-diagnostic. This thick colloid-like extracellular mucin is diagnostic of a mucinous cyst. So even if you don't see extracellular, epithelial cyst lining epithelium, this quality and quantity of extracellular mucin is diagnostic of a mucinous cyst. So in this example, a 2.5 centimeter unilocular cyst in the pancreatic tail might have a scant cellularity or absent epithelial component. I'm comfortable that this represents a mucinous neoplastic cyst, so I'm going to put it in the pancreaticobiliary low risk, low grade category. I'm going to describe it. I'm going to say that I don't have epithelium to grade it. It could be a sampling error, you know, could be high grade, but I don't have it on my slide, and they need to correlate it with their imaging. If there's a mural nodule that increases the risk, they should separately aspirate that. So category 2 is the benign or negative for malignancy category. It demonstrates an unequivocal benign cytopathological features that may or may not be diagnostic of a specific process or benign neoplasm. And as I said, in contrast to the PSC, this system includes both non-neoplastic and benign neoplastic lesions, and the neoplastic lesions are going to be dominated by your serous cystadenoma. It can also include normal pancreatic epithelium without a defined mass. So if I have a vague fullness or no discrete lesion, and they aspirate and only get benign pancreatic tissue, I would put that in the benign or negative category. The risk of malignancy for pancreatic FNA is up to 15%, and for bile duct brushings is up to 25%. The management is conservative with clinical correlation. And in the online WHO book, this is the categories that will be described. Everything from pancreatitis to lymphoepithelial cysts, pseudocysts, splenial, serous cystadenoma, schwannoma, lymphangioma, and other rare benign neoplasms. And as I mentioned earlier, the serous cystadenoma will be the dominant neoplasm. They're multilobulated, multicystic masses. They're lined by cuboidal, glycogen-rich, non-mucinous epithelium, which is very delicate and often gets destroyed during the FNA process. Liquid-based processing preserves the epithelium a little bit better, but direct smears, these cells often get stripped of their very delicate cytoplasm and they're hard to see. Because the septae are very vascular, they bleed, and that's why these hemosiderin-laden macrophages can act as a surrogate marker. These cysts have low CEA and low amylase, and some of them will have a 3P gene mutation, von Hippel-Lindau gene mutation. So here's an example, multicystic mass in the pancreatic head of a 75-year-old female. And often the age can be very informative. Grandmother's tumor, so older females. So it's a scant cellularity, benign serous cystadenoma. Make a diagnosis above the line if you're confident about it. And then in a note, you can describe the characteristics that led you to make that diagnosis. Here's an example of a solid and focally cystic mass. Because these are often microcystic, they can look quite, and the clinicians don't have a clue that these are serous cystadenomas. And here's an example of a diff-quick with the non-mucinous, bland appearing cuboidal epithelium. Here's a sharp core biopsy showing how that dense fibrous septae can preclude getting any kind of epithelium on your FNA. And these delicate non-mucinous epithelial cells that stain with inhibin, they also stain with GLUT1, and this combination makes a definitive diagnosis of benign serous cystadenoma. Here's an example, a 65-year-old man with diffusely enlarged pancreas and an ill-defined mass in the pancreatic head. We can say there's a scant epithelial component because the smears are dominated by these very cellular stromal fragments embedded with inflammatory cells with an inflammatory background. Negative for malignancy, or you could say benign. Benign ductal and acinar tissue with cellular stromal fragments embedded with lymphocytes and plasma cells. And I would say suggestive of autoimmune pancreatitis. Rather than definitive for. It's a difficult diagnosis to make on small tissue specimens, but at least we raise the specter of autoimmune pancreatitis, which allows the clinical team to treat the patient with steroids to see if there's a response. Here's an example of a 65-year-old man with alcohol abuse and an ill-defined mass in the pancreatic tail. Ill-defined, not hypoechoic and well-defined, but an ill-defined mass. That history is very important. And when we look under the microscope, we see this autolyzed saponified fat, degenerated cells, acinar tissue, ductal cells, mucoid inflammatory debris, all supporting the diagnosis of chronic pancreatitis, which goes along with the alcohol abuse. You can write a note explaining why you came with that diagnosis, what you said. Here's an example of a 1.5 centimeter round mass in the pancreatic tail. Evaluation limited by poor cellular preservation. But it's benign because I recognize that these poorly preserved cells are squamous cells and squamous debris, keratinous debris, and a background of lymphocytes. It's very important to recognize this degenerated debris as a lymphoepithelial cyst because this patient does not need any surgery. Keep in mind that if you get enough liquefied fluid from these lesions, that the CEA can be very high. And this can be a pitfall that I have fallen down with this pitfall before. In assuming that this CEA, a very high CEA, says that this is a mucinous cyst. Not with this type of cytology though. Sometimes this debris can be so liquefied that the fluid that's pulled out of the cyst looks clear and white and thick and mucoid, and it's not. Hopefully you'll get an aspirate that shows this keratinous debris and the lymphocytes in the background. So morphology plus ancillary tests comes up with the correct diagnosis of a lymphoepithelial cyst. One pitfall to always remember for those trainees out there, it'll probably be on your boards. A 55-year-old female with pancreatitis and a 7-centimeter pancreatic tail cyst. So pancreatitis is key here, large cyst. And all you see is these histiocytes, inflammatory debris, hematoidin, yellow pigment in the background, and no epithelial cells. With that history, that size, I look at the EUS report and see that the gastroenterologist got thin fluid, not thick fluid, then I'm comfortable that this is a non-mucinous cyst consistent with a pseudocyst, and describe in the background what makes me come up with that diagnosis. Keep in mind that you can, in these EUS biopsies, GI epithelium can be a pitfall, so make sure that epithelium isn't interpreted as cyst lining epithelium. You want to have a very high amylase in these pseudocysts as well. Don't make a diagnosis of a pseudocyst with an amylase of 100. It needs to be, usually in the thousands, and CEA is low. 2-centimeter well-defined round mass in the pancreatic tail, clinically thought to be a neuroendocrine tumor. And what we see are a lot of blue cells. They look lymphoid. Our cell block shows this vascular lymphoid type tissue. We do a CD8 and that confirms the splenic endothelial cells, making a diagnosis of a splenial or ectopic spleen instead of a neuroendocrine tumor, again, saving the patient from an unnecessary pancreatectomy. Now, the atypical category is one that predominantly shows minimal features of malignancy. Just a few atypical cells, too much to call benign and negative, not enough to call suspicious or classify a lesion in the pan-low or pan-high category, certainly not enough for a malignant diagnosis. So it leans towards the benign, but it has a risk of malignancy of up to 40%. You just don't have the quality or the quantity to go past atypical. In bile duct brushings, we know that the risk of malignancy is even higher, up to 50%. And because we are very conservative, at least I'm very conservative in my interpretation of bile duct brushings, because of the known underlying inherent inflammatory and reactive changes that can occur from the lesions in the bile duct. Stents are often in place. In PSC, there's an inflammatory background, so have a high threshold for malignancy. We don't want to be wrong when we say something is malignant. Clinical management is to repeat the procedure, preferably with some type of ancillary study, FISH, or next-gen sequencing. At Mass General, we co-test all of our bile duct brushings with next-gen sequencing because they're so difficult to interpret. So here's an example, a 2.5 centimeter unilocular cyst in the pancreatic head. It's benign on imaging, low risk on imaging. The CEA is elevated, but it's not, again, above our threshold, so we can't put it in the pan-low category. You could, if you were comfortable that this mucin was lesional. Sometimes it can be very difficult to be sure that the mucin is lesional. Thick colloid-like mucin is lesional, but sometimes this wispy mucin can be difficult to distinguish from GI contamination. It all depends on the quality and quantity and what you see on the smear. The epithelium certainly It suggests that this is lesional, that these are cyst lining epithelium, but they're very degenerated. You're just not sure. So the atypical category would be where you'd put a case like this. Here's an example of a 32-year-old man with PSC and an intrahepatic bile duct stricture. We call this atypical, but favored this being reactive. The cells look very round and regular. There seemed to be ample cytoplasm. They're all about the same size and shape. Yes, mitotic figure, but that doesn't make anything malignant. It looked very bland. We did do ancillary studies that weren't available at the time of sign out, but they came back later as negative for FISH, but the next-gen sequencing showed a KRAS mutation and a P53 deletion. Those are concerning. KRAS says I'm likely dealing with a neoplasm, and P53 is a high-risk mutation. Well, this patient had a repeat showing the same mutations, and he went to hepatectomy, which showed the background PSC, but foci of high-grade dysplasia. So we definitely continue to co-test all of our bile duct brushings with next-gen sequencing, and we've shown in studies that it was as good, if not better, than FISH, and others have validated next-gen sequencing into their routine evaluation of bile duct brushings. At UPMC, they get a lot of specimens. They have a Biliary panel that they do for their bile duct specimens. Now, going on to the pancreaticobiliary neoplastic categories, as I mentioned, they're going to be predominantly intraductal neoplasia dominated by IPMNs. So in these intraductal lesions, we have two questions to answer. Is it mucinous or non-mucinous? And is it low risk or high risk? So mucinous etiology is established by the evaluation of the extracellular mucin, which can be done grossly. Thick, sticky, opaque, white, fluid that gives you a string sign. You can string it between your fingers, or you can smear it on a slide and it's slick and sticky. But you can also look under the microscope and see this colloid-like, see the cracking like colloid-like extracellular mucin. This is neoplastic mucin, defines a mucinous cyst in the pancreas. It's not GI contamination. And notice the ferning. You can see this mucin actually crystallizes and ferns. We can also do it by biochemical testing. CEA greater than 192 nanograms per milliliter is a mucinous cyst, keeping in mind that rare pitfall of a lymphoepithelial cyst that we just discussed. And also molecular testing. KRAS, GNAS, ring finger 43, these mutations support that you're dealing with a mucinous cyst, but they do not stratify for grade. All it tells you is you're dealing with a mucinous cyst. So these are the ways that you can define the mucinous etiology. But then we have to grade the cyst, and we do that with cytology, and if you do next-gen sequencing by the detection of high-risk mutations. So we look at the cytology to say whether it's low-grade, low-risk, and that includes low-grade dysplasia, which looks like benign mucinous epithelium, to moderately atypical intermediate-grade dysplasia, pseudostratified mucinous epithelium. These are both low-grade. And distinguishing that from high-grade epithelial atypia that includes these small high NC ratio cells. They're smaller than a 12-micron duodenal enterocyte. They have abnormal chromatin. It can be hyper or hypo. Usually they do have irregular nuclear membranes, but not all cells will have nuclear membrane abnormalities. And the variable amounts of residual cytoplasmic mucin. The background necrosis is often present, but it's not always present. And there usually are, a good number of these cells. They're not just one or two cells. So low grade, low risk, high grade, high risk based on epithelium. supported by next-gen sequencing. These mutations support a neoplasm, do not stratify for grade, but a P53 mutation, SMAD4 deletion, P16 deletion, all support a high-risk cyst. And that information, if you do molecular on these cyst fluids, will come out about 1 to 2 weeks after you sign out the case. So for the pancreatic neoplasm, low risk, low grade, pan-low is one where the features of the intraductal or cystic neoplasm has low-grade epithelial atypia. It's extracted from the neoplastic other category in the PSC system, and it encompasses low-risk lesions that have low risk for progression to malignancy, and it's dominated by your low-grade IPMN. It can also include low-grade spindle cell lesions, as I mentioned in the categories, schwannoma, leiomyoma. So pancreatic neoplasm, low risk, low grade, is not likely to be used for bile duct brushings. As I mentioned earlier, you're more likely to use the atypical category in those that are slightly atypical, you can't call benign. If you incorporate ancillary studies, CEA, amylase, NGS, you can categorize lesions that might not have a lot of cells into this category. The risk of malignancy is up to 20%. It's not yet established in bile duct brushings, and the clinical management is usually conservative. Here's the list of lesions in the WHO, and it will be dominated by your low-grade IPMNs. So low-grade epithelium is benign, pseudostratified, intermediate grade, or you may not even have epithelium at all. You may just have this thick colloid-like mucin, which you can classify in this category based on that mucin, with a caveat that you don't have any epithelium to really grade it, but you can classify it as neoplastic. So an example, an 80-year-old man with a 3-centimeter unilocular cyst in the pancreatic head. It's a mucinous cyst fluid with low-grade dysplasia, pan-low category. Low-grade dysplastic epithelium is present in a transduodenal FNA, abundant extracellular mucin, CEA is elevated, so you have all additional support that this is a mucinous cyst with epithelium that looks low-grade. And here is just another example of how the mucin in a low-risk looking cyst supports a low-grade, low-risk cyst. Now the pan-high category has features of an intraductal or cystic neoplasm with high-grade epithelial atypia. It's extracted from the neoplastic other category, and it encompasses high-grade dysplasia, possibly carcinoma. Sometimes we can't rule out an invasive carcinoma, and that lesion has a high risk of progression to invasive carcinoma. In bile duct brushings, we're more likely to use suspicious for malignancy instead. We're not quite able to call it malignant, but we're worried about it. Risk of malignancy in this category would be up to 95%. For pancreatic FNAs, is not yet established or used in bile duct brushings, and again, clinical management would be resection. So the high-grade epithelial atypia in a pancreatic cyst, these small high NC ratio cells, background necrosis, and also included in this category is the IOPN, intraductal oncocytic papillary neoplasm, very distinctive by its granular eosinophilic cytoplasm, oncocytic type cytoplasm. Here are the lesions listed in the WHO. And here's an example, a 68-year-old man with a 3-centimeter cyst and a mural nodule. That's a high-risk imaging characteristic. We see the background necrosis. We see these high NC ratio cells with irregular chromatin, irregular nuclear membranes. You don't have to have very many, but I can't call these benign. I can't call them low grade. I can't call it intermediate grade. This looks high grade to me. So mucinous cyst with high-grade epithelial atypia. Now, I can't say it's an IPMN versus a mucinous cystic neoplasm definitively just on cytology, but the fact that it's a man, more likely than not, is going to be an IPMN. No thick extracellular mucin, CEA is very elevated. That adds support to the mucinous etiology. The molecular is pending, but the epithelial cells certainly support this being a high-grade cyst. Now, suspicious for malignancy also has a high risk of malignancy, up to 100% in some studies, but 80 to 100%, 75 to 90% for bile duct brushings. And management is repeat if the patient's going to undergo neoadjuvant therapy to try to get to a positive diagnosis. In some clinical circumstances, the patient may go directly to surgical resection. So an example, a 2-centimeter round, well-circumscribed mass in the pancreatic tail may only be called suspicious for a neuroendocrine tumor because I don't have any material for ancillary tests. The differential diagnosis for something like this would be axonal cell carcinoma, even pancreatoblastoma. The likelihood that it's a neuroendocrine tumor is high, but I don't have anything to confirm it. So I put it in the suspicious for malignancy category. Similarly, if I don't have tissue to support, to get ancillary studies to support an axonal cell carcinoma, this is a solid cellular, non-ductal appearing neoplasm with a monomorphic population of tumor cells with the differential of endocrine, acinar, solid pseudopapillary tumor. So we need tissue to confirm the diagnosis, and without that, suspicious for malignancy would be appropriate. Specimen that demonstrates an unequivocal cytopathological features of malignancy is malignant. The risk of malignancy is 99 to 100% for pancreatic FNAs, and for bile duct brushings is 96 to 100%. So we have high specificity when we say something is malignant, very few false positive diagnoses, and management would be per clinical stage. Here's the list of lesions in the malignant category. Pancreatic ductal adenocarcinoma, as you know, is going to represent the vast majority in this category. About 9 out of 10 malignancies in the pancreas are going to be ductal adenocarcinoma, with your non-ductal acinar, neuroendocrine tumor and carcinoma, pancreatoblastoma, and now solid pseudopapillary neoplasm is in this category. And it's dominated by your PDAC, which is not that hard to diagnose when they're high grade, but can be very challenging to diagnose when they're low grade looking, well differentiated looking. And neuroendocrine tumors and solid pseudopapillary neoplasms are in this category. So for example, a 1.5 centimeter round mass is in the pancreatic tail. Here, I'm going to call it definitively malignant and well differentiated, even though I don't have any tissue for ancillary studies. This morphology to me is absolutely diagnostic, and I'm willing to call it above the line that this is a well differentiated neuroendocrine tumor. Here's an example of a 28-year-old female with a solid and cystic pancreatic head. That history alone tells me I'm more likely than not dealing with this neoplasm. Young female, solid and cystic. It's a solid pseudopapillary tumor until proven otherwise. Neuroendocrine tumors can also look like this. But here's the characteristic morphology with the myxoid stroma, the papillary architecture, and the immunostain that's best for confirming this diagnosis is your beta-catenin, which gives you nuclear staining. It can also give cytoplasmic staining, but you want to see nuclear staining for this diagnosis. Here's an example of a 68-year-old man with jaundice and a 3-centimeter hypoechoic irregular mass, malignant, well-differentiated adenocarcinoma. We can see the drunken honeycomb pattern, the round regular nuclei, a little bit of crowding, abundant cytoplasm. If you have any doubts that this is adenocarcinoma, you can add some ancillary stains. For example, SMAD4, showing loss of nuclear staining, supports the diagnosis. So more often than not, you just have a straightforward adenocarcinoma, and you don't need to say another word. Malignant adenocarcinoma, if you want to describe it in a note, you can, but I think it's very clear when you make a definitive diagnosis above the line, you don't need to say anything else. There can be circumstances that where you have a cyst with a mural nodule or a mass in the wall of the cyst, which is suspicious for a malignant IPMN or an IPMN with invasive carcinoma. Be sure that in those cases that your gastroenterologist separately aspirate the nodule or mass in the wall. You can get a cyst aspirate contents that show high-grade epithelial atypia that supports this being a high-risk cyst, but to definitively adenocarcinoma, you need to separately aspirate that nodule. So here's an example, a 4-centimeter cyst with a mural nodule, satisfactory and malignant, putting part A and part B together. I can call it an adenocarcinoma associated with a mucinous cyst with high-grade atypia, consistent with the clinical and imaging features of an invasive carcinoma arising in an IPMN. Here's an example of a solid mass in the pancreatic head showing this non-ductal proliferation. It could be endocrine, it could be acinar, really does help to have immunostains. This was a tumor that was positive for trypsin and BCL10 and negative for the endocrine markers, supporting the diagnosis of acinar cell carcinoma. Let's not forget our metastatic neoplasms to the pancreas. Lung, breast, melanoma, kidney are all lesions that go to the pancreas. I want to emphasize, though, that kidney is the one that can metastasize to the pancreas decades after the nephrectomy. It can metastasize as a solid nodule, single solid nodule, not necessarily multiple lesions. It can mimic a primary tumor in the pancreas, and it can also look like a foamy gland variant of adenocarcinoma or even a lipid-rich variant of neuroendocrine tumor. These lesions have cells, clear cell renal cell carcinoma of large polygonal cells with these punched out vacuoles in the cytoplasm, round nuclei, prominent nucleoli. If you know the patient has a history of renal cell carcinoma with this morphology, I think you could probably safely call it a renal cell metastasis. It often helps to do immunostains to support that. With a PAX8, immunostain would be sufficient. So in summary, we have a new WHO classification system that builds off of the PSC reporting system for pancreaticobiliary cytology that now has serous cystadenomas and other benign neoplasms in the benign category, and divides the neoplastic category, benign and other, into pan low and pan high. Now we have our intraductal and cystic lesions divided between low grade and high grade, high risk and low risk lesions. And then we have our suspicious and our malignant category, where now neuroendocrine tumors and solid pseudopapillary neoplasms are in the malignant category. So with that, I think I'm exactly on an hour. I hope I still have time to take questions if you have any. Thank you very much for your attention.
Thank you very much, Dr. Pitman, for this wonderful talk. And I'm very happy that you and also the committee decided to couple the classification with the WHO Blue Book for histological tumor classification. This is really an excellent idea. Do you know when your book will be out? Will be published?
The pancreaticobiliary text has been 99% done. We still have a few punch list items to go over. It needs to go to technical editing, and how long it takes for the IARC to have their technical editing and production remains to be determined, but we hope by the end of the year.
Okay, good news. Thank you very much.
Mm-hmm.
So we have time for a couple of questions from the audience. The first one is from Mark Chen from Taiwan. And he said that a pancreatic cystic lesion is always low cellular and challenging, either with mucinous or non-mucinous materials. Just like I think is salivary gland FNA, probably we need more ancillary tests and clinical information.
So the question was what about? I'm sorry, I missed the question part.
Yeah, it's a comment about the necessity to have more ancillary tests and clinical information in pancreatic cysts.
Oh, yes. Absolutely having the ancillary test for the diagnosis of pancreatic cysts is critical. More often than not, you will say non-diagnostic or atypical or something like that, which is really not helping the clinicians. They want to know, are they dealing with a mucinous cyst or a non-mucinous cyst? Because that's going to direct their management. Are they going to follow that patient serially forever and track this pre-malignant cyst to progression? Or are they going to leave the patient alone because it's nothing to worry about? It's a non-mucinous cyst, a pseudocyst, or a serous cyst. And if it's a mucinous cyst, they need to know if there are any high-risk features. They can get a lot of that from imaging, but as we know, imaging isn't everything, and cytology is very important. So from our cells that we have in the cyst fluid, we can determine whether or not it's low risk or high risk as best we can using the criteria, but also ancillary tests. So the ancillary test, CEA, greater than 192, supports a mucinous cyst.
Mm-hmm.
And then the molecular testing, even if you don't have epithelial cells, supports whether you have a neoplasm, if you have a KRAS mutation, a GNAS mutation would support an IPMN, ring finger supports a mucinous cyst. And then the late mutations, the 4 pillars of pancreatic cancer, the P53, SMAD4, P16 and KRAS, those 4 pillars are the more common mutations that we know occur in pancreatic cancer. KRAS doesn't stratify for grade, but the other 3 are high-risk mutations that support progression and warrant a serious consideration for resection. We want to get these cysts out before they become invasive carcinoma. Mm-hmm. We don't want to wait for the imaging to show a big solid mass in the wall of the cyst or a complex solid and cystic mass. We want to get them out when they don't look necessarily malignant on imaging. And that's why we aspirate them and why we look at them and why we do molecular testing.
Yeah, always Mark Chen from Taiwan is asking about ROSE, rapid on-site evaluation, in case of a non-diagnostic category for a cystic lesion. Do we need more aspirates if a fluid is not prominent?
So my recommendation is that you don't do rapid on-site evaluation for pancreatic cysts. It's a waste of time, it's a waste of resources, and it's a waste of that precious cyst fluid. Because the typical approach to a pancreatic cyst is that you aspirate the cyst fluid as much as you can. And that's all you can do. You're not going to go back and do anything else once you take the cyst fluid out. The only thing you'll do additionally from the gastroenterologist point of view is to aspirate a solid mural nodule or a mass in the wall. And then you're done. And then you have to wait. There's nothing else you're going to do. So for the cyst fluid, particularly in these low risk looking cysts that don't have a mural nodule or cyst, they're just going to drain the fluid as much as they can and they'll be done. So you want to use every drop of that fluid for processing, not for making direct smears. You want to be able to do your CEA. You want to take an aliquot for molecular if you have that available, and you want to do like a cytospin for your cytology. If you dump it into cytorich red or thin prep solution preserve site, you don't get the background elements, the quality of the mucin, the inflammation, the necrosis that would be so obvious on a cytos. It's diluted and attenuated in these liquid-based mediums. So we triage our cyst fluid in our cytology processing lab. We ask that the gastroenterologist send us the fluid, 100% of the fluid, fresh and undiluted, We take a small aliquot off the top and send it for molecular. We spin down the rest of the fluid and make a cytospin for cytology. And then we send the supernatant of that to the chemistry lab for CEA and amylase.
And concerning NGS, do you have a specific pancreatic panel for a cystic lesion? This is a question from Adriana Castiblanco.
No, we don't. We use our full NGS panel. And we've, we've found many other mutations that hopefully one day we can analyze and show that they have a, an association with malignancy as well. If you look at the data from UPMC, Dr. Archer Singhi has published a lot on pancreatic cyst as well as bile duct brushings. At UPMC, they have a panel called Pancreatic and one for bile duct brushings called Biliary. And they look at other mutations in a specific panel, but we do our full NGS panel.
Mm-hmm. And do you recommend to do NGS to all pancreatic cysts?
Say that again, I'm sorry.
Do you recommend to perform NGS in all cases of pancreatic cysts?
That's the holy grail. If you can, yes. If you have that ability, yes. And we have been doing this for a long time. And we have finally gotten the government and insurance companies to pay for it. We find that the benefit of looking at the molecular fingerprint of these cyst and bile duct brushings pays for itself down the road with added specificity and granularity of information about what's going on in these strictures and in these cysts. So if you can do it, I would do it.
Okay. Another question from Norizal. Does SMAD4 help to differentiate reactive ductal versus malignant cells?
In my experience, yes. It doesn't 100% distinguish between high-grade dysplasia and carcinoma, but it does highlight a high-risk progressed lesion that warrants consideration for resection. In my experience, the SMAD4 loss of nuclear staining or the finding of an NGS mutation or deletion in SMAD4 is associated with reactive ducts. That's not the experience that I've seen or had or seen that published.
So another couple of questions if you have time. Why NET grade 1 is now in the malignant category?
Why is pancreatic neuroendocrine tumor grade 1?
Grade 1, yeah.
Because that's the way they're classified in the WHO. And I understand the concern about that. I'm not 100% sure. My surgeons are going to be very happy with moving neuroendocrine tumors from the neoplastic other category, because the conservative management of these small low-grade pancreatic neuroendocrine tumors is increasing. They're not all removed in high-risk surgical candidates. But that said, we're following the WHO classification, and neuroendocrine tumors, all grades are classified as malignant.
Another question, the processing of a specimen of pancreatic cyst is in the next WHO guidelines?
The processing, yes.
Yeah.
I will make sure that there are more details in there. I will double check that. Yes, triage.
And if you don't have a fresh liquid, what do you suggest in case of fixation or in case of fixation of the material, cytolite or so on?
I think you're at a disadvantage if your cyst fluid is put straight into a liquid-based processing, unless it's so cellular that you can make a cell block.
Okay.
If you can make a cell block and get something from that, that may be helpful. But as most people know, these cysts are very paucicellular. Unless the imaging is so complex and the cyst is so big and already malignant that you're going to get a lot of cells out of it.
Yeah. Thank you. This answer also another question about the use of cell block in cystic lesion. Thank you, Marta. I think we are at the end of this webinar. There are a lot of comments thanking you for this very informative session and talk. And thank you again also on my side. And everyone can look again at this webinar on our YouTube channel, and also stay tuned on the International Academy of Cytology website to check for a new talk. Thank you very much, Marta.
For having me. It's been a pleasure. Thank you, Dr.
Thank you.
Bongiovanni.
Bye-bye to everyone.